Thank you very much for inviting me to give this address. I wanted to acknowledge the outstanding arrangements of the EAU coming from North America, particularly the subtle things I'm looking at, the sugar cookie and the kidney flowers and the bladder tulip, and that's just emblematic of the high organization. Thank you very much for allowing me to participate, although I am a member and have been for many years. Today is Canada Day in Canada, where we are celebrating our annual anniversary, although it's tempered a bit by what's been happening in Europe. And I can tell you that 1 in 30 Canadians are Ukrainian, so there's a huge support. And it's not that many years ago the Canadians were just a few kilometers from here, in the picture in the lower right. Many thousands of Canadians are still here. So it's in some ways a sad thing. I want to talk to you about an evolution of my own philosophy over 50 years of uro-oncology practice in my city, Toronto, at the University of Toronto, and I've been privileged to operate in a cancer center and a general hospital that are amongst the top 5 in the world, repeatedly voted as such. And there has been huge transformations. We've heard some of it today, and we'll hear more over the next 3 days in healthcare. But the thing that is sticking with me now is how better to use the voice of our patients to deliver higher quality care. And I'm going to try to talk to you a little bit and maybe provoke you to think about this as you leave today. The evolution of patient-centered care is about a 40-year evolution in North America, and it's also occurred in Europe. But there are a couple of standout publications that help to focus this from the Institute of Medicine in the United States. And the first one that really used this term patient-centeredness or patient-centered care was this publication about 20 years ago, Crossing the Quality Chasm. The focus was on quality, and yet it focused also on an essential ingredient of quality, which is care that is more than just of patients, but is centered on the respect for the individual and to be responsive to that individual's preferences, needs, and values, and that be used to decide and guide clinical decisions. So we all went to medical school to look after patients. That was our focus. But this interactivity and to listen to the voice and wisdom of that patient was not necessarily part of my upbringing, but I've evolved to think more about it. This is a second publication about 10 years ago that further developed the concept of quality centering on patient-centered care. And yes, the patient's in the center, and we are the clinical workforce around this. We, clinicians, nurses, therapists, physicians, surgeons. And in an environment of high-level evidence with information systems, we've come to live with quality measurement, quality improvement strategies, and measuring the impact of those on our patients' care. What has really been part of that, though, is involving our patients in every aspect of the decision making. And this has led me in the last 20 years to support my patients to form national advocacy groups, particularly in bladder and kidney, and in the last 7 years to be part of an international consortium of kidney cancer networks called the IKCC, International Kidney Cancer Coalition. The EAU has been particularly outstanding in identifying the value of patient involvement in care. So it's a great honor to speak about this and to represent almost 50 groups in the world as a member of the board of this organization and to chair the medical advisory board, of which some of you are in this room. And over the last 2 years of pandemic, we've met virtually and we've talked about how we can do more than support our patients, what I call the bottom up, to engage our physicians, our colleagues, to expedite this and to engage with the patients to bring this to pass faster, to engage them. And there were two initiatives that came of this. And the first is what I'm doing today, which is to deliver the first lecture from the IKCC to clinicians at a major clinical meeting. And it is so good to see so many of you stay here and listen to this, and hopefully persuade you about the value of patient engagement. And about 5 years ago, this study was presented at ASCO and then as a letter in JAMA that showed a secondary outcome that was unexpected of managing over 700 patients with metastatic disease in New York. And these patients were randomized so that half approximately had access to a reporting system of side effects of their systemic therapy that allowed earlier therapy change, discontinuing drug, increasing dose. And what was unexpected was an overall survival advantage of those patients that were allowed access to this compared to those who had standard of care. And we can see here over time, durably, year after year, that there is at least a 10% survival advantage amongst those patients who were otherwise managed for the same mix of cancers with multiple systemic agents. So it appeared that this engagement strategy actually produced an equivalent of a drug blockbuster effect. It was a therapy. So this lecture, I picked the subject, and I realize it's slightly dramatic, but that patient engagement is a potential blockbuster treatment, and urologists should prescribe patient engagement for their cancer patients, just as the things we've heard about this morning over the last 2 hours are things you do as active interventions. And I want to touch on these 4 learning objectives. I want to be clear what patient engagement means, what the impacts can be, not just on the qualitative coping mechanisms, length of stay and so forth, but also on hard outcomes such as overall survival. And lastly, to go home and encourage your patients and your colleagues to engage in advocacy and support the engagement of your patients in their care. So let's start by what is patient engagement, and it's variously defined, but it involves activating your patients to manage their own health care. And that can be done in a variety of ways, which I'll touch on. And the objective of this is to both increase their awareness and skills in self-management, but that by taking better care of themselves and their own illness will affect the outcomes. So we started by doing a literature review of interventions in cancer care to look at what outcomes were affected by that. And we found up to 2020, 82 reports that were formal RCTs, almost 20,000 patients. These are cancer patients, the majority of which were breast and prostate, but that's not surprising, following appropriate guidelines for doing scoping reviews. And in summary, what we found in approximately 90% of these papers that addressed what I call qualitative outcomes, emotional well-being, coping strategies, physical well-being, including less fatigue, improved quality of life in general, as specifically disease, importantly, self-care and compliance with their treatment, which may be part of the reason that there are survival advantages associated with these, that the patients followed through on their therapy. In the small number of papers that actually measured survival, there were varied results, but about half of them showed survival advantages of various sorts. In other words, by engaging them, their lives were prolonged. And here are a couple more papers that I won't dwell on, but this is in breast cancer. These are regional breast cancer patients, and they received a bi-weekly psychological support session that involved education, and you can see very clearly all survival metrics were improved by that strategy. Not all of these breast studies have shown that, but this one did. And here is an AML population were a similar intensive program that involved not just psychotherapy, but also physical exercise and other informational sessions, that the events of depression were less, but more importantly for you in this audience perhaps, who are used to seeing these kind of survival curves in drug therapy, here is an intervention that looks like a drug therapy. It looks like it could lead to registration of a drug at the FDA or an EMA in Europe if you have these kinds of differences. So I want to go on briefly and talk a little more about this coalition of kidney cancer patients who I am speaking on behalf of, but I'm really speaking on behalf of all cancer and other disease patients. This is a screenshot of the website, ikcc.org, and some of the resources that reflect the activities of this organization, including running an annual Kidney Cancer Day every June. A couple of weeks ago, bringing the representatives together for a meeting to share best practices every year, participating in guidelines. These are patients on guideline committees. It's becoming ubiquitous across North America and Europe to recognize the value of patients' perspective. Their voice is represented in our guidelines here at the EAU. This is an interesting project to demonstrate trials in a graphic, what we call them infographics, and these are trials we've heard about here today, where patients can see who was, in what countries the studies were done, what the actual study was, how many patients by risk stratification were in the study, and what the outcomes were being. For example, here, complete responses shown in the treatment arm versus the control arm. And these are resources that we as clinicians can easily use to talk to each other as well as to talk to our patients. Big investment in shared decision-making, another element. It's important in engaging our patients, and some very useful tools that can be downloaded at no cost to be given to your patients, or give them access to them, and just to navigate them to them so they can be involved in making the choice that is best for them. Patients have been involved increasingly in setting research priorities. We went through this process in Canada a number of years ago. In Britain, it's just been done again, has recently been reported by Professor Stewart's groups. I'm not familiar with the exact outcomes, but to sit around a room with half of those experts being patients with the disease, I can tell you, is an almost spiritual experience. The second initiative of our board of the IKCC is to sponsor a workshop that will take place at the end of ESMO in September, where we're bringing together between 20 and 30 clinicians, oncologists, to discuss with a faculty of experts, much more expert than I, on the science and the knowledge base of advocacy, to hopefully have them go home and to not only mentor their colleagues, but to interact more with their national patient populations, because we live in a land of plenty in Europe here and in North America in resources around patient engagement, but there are many parts of the world where culturally it isn't even possible to talk about having cancer. It jeopardizes employment and other relationships. So, in summary, today, I hope I've left you with a little more thoughtful understanding of what patient engagement means and what its impact can be, which is potentially blockbuster-like with drugs that we spend tens of thousands of dollars a month on, and to encourage not only our patients but also our colleagues to participate in engagement. And it's my hope one day that this will be a line item in the payer's budget of healthcare, because it's going to be a cheaper way to achieve an improvement in outcome. Thank you very much.